All right, let's jump right into abnormal uterine bleeding. If you're a med student, you know this is a topic that comes up all the time. We're going to break it down with a really powerful framework that's going to help you nail your exams and, just as importantly, feel a lot more confident on your clinical rotations. So, here's our plan for this explainer. We'll start with the basics. What exactly are we talking about when we say AUB? Then we'll get into the Palm-Cohen framework, which is honestly your key to the whole thing. After that, we'll walk through the clinical workup, talk about management, and finish up with a clinical pearl you will definitely want to remember. Okay, first things first. We need to get our terms straight. In medicine, being precise with our language isn't just about sounding smart. It's actually the very first step toward making an accurate diagnosis. So what is abnormal uterine bleeding, or AUB? Well, simply put, it's any bleeding from the uterus that's just off. It could be the duration, the volume, the frequency, or the regularity. And, the most crucial first step, always, is to make sure the patient isn't pregnant. But AUB is a huge umbrella term, so our next job is to start narrowing it down. The first big split we make is between chronic and acute AUB. So think of chronic AUB as a more persistent, ongoing problem. We're talking about abnormal bleeding that's been happening for at least 6 months. Acute AUB, on the other hand, well, that's a whole different ballgame. It's a medical emergency. This is heavy bleeding that needs immediate intervention to stop further blood loss. Okay, now for what is arguably the most important tool in your AUB toolkit, the Palm-Cohen framework. This system was developed by the International Federation of Gynecology and Obstetrics, or FIGO, and it's how we systematically think through every single possible cause of AUB. It's a real game changer. Seriously, think of this mnemonic as your diagnostic checklist. It's what ensures you don't miss a single thing when you're working up a patient with abnormal bleeding. And the real beauty of this framework is just how simple its division is. You've got the PALM side, which covers all the structural causes. Things you can often literally see on an ultrasound or identify through pathology. Then you have the Cohen side, which covers the non-structural causes. These are more about systemic issues, hormones, or maybe medications. So let's break each one down. So let's start with the PALM causes, which are all about the physical structure of the uterus itself. P is for polyps. These are little overgrowths of the uterine lining that are fragile and can bleed easily. A is for adenomyosis, which is when that same lining actually invades the muscle of the uterus. This makes the uterus bulky and tender, and it just can't contract effectively, which causes heavy bleeding. L is for leiomyomas. You know them as fibroids. They're benign tumors that can distort the uterine cavity, which increases the surface area of the lining and leads to heavier periods. And finally, M, the big one we absolutely cannot miss, malignancy and hyperplasia or endometrial cancer. This causes bleeding as the tumor grows and starts to erode into blood vessels. Now, moving over to the non-structural causes, let's start with a number that might actually surprise you. Up to 20%, 1 in 5, women with heavy menstrual bleeding have an underlying coagulopathy, a bleeding disorder. And this is exactly why taking a thorough personal and family history of bleeding is so critical. So, the COWEAN causes. C is for coagulopathy, which we just mentioned. Now, O is for ovulatory dysfunction, and this is a huge one. Think about conditions like PCOS or the hormonal chaos of perimenopause. They can lead to cycles where there's no ovulation, which means you get prolonged exposure to estrogen without any progesterone to balance it out. This unopposed estrogen makes the uterine lining get super thick, unstable, and really prone to heavy, irregular bleeding. E for endometrial polyp is basically a diagnosis of exclusion. I for iatrogenic covers bleeding caused by things we do, medications or medical devices. And finally, N is for not otherwise classified, which catches the rare stuff. Okay, so we've got our Palm-Cohen framework. How do we actually apply this when we see a patient? Well, a structured, systematic workup is absolutely key to getting to the right diagnosis without wasting time. The workup really follows that classic 3-step process we all know and love. First, a targeted history. You're basically a detective, listening for clues that point you toward a specific category in Palm-Cohen. Next, the physical exam. You're looking for signs of anemia, feeling for an enlarged uterus, and finally, you move on to investigations, which are totally guided by what you found so far. When it comes to investigations, a full blood count, or FBC, is absolutely non-negotiable. You have to check for anemia. A transvaginal ultrasound is going to be your best first imaging test to look for those structural PALM causes. And what about coagulation studies? Well, you only order those if the history is really suspicious for a bleeding disorder. This leads us to a really critical decision point. When do you need to actually sample the endometrium with a biopsy? This is all about ruling out that M in PALM, malignancy. The decision to biopsy really just comes down to risk. The single biggest risk factor is age, so any woman over 45 with new onset AUB, she's getting a biopsy. Other red flags are things like persistent bleeding even after you've tried treatment, or in younger women, having specific risk factors like obesity or PCOS. Remember, these conditions can lead to that state of unopposed estrogen we talked about, which can cause the endometrium to overgrow and, potentially, become malignant. All right, you've used Palm Cohen, you've done your workup, and you have a diagnosis. Now what? How do we manage it? Well, there's no single right answer here. Treatment has to be tailored to the underlying cause, the severity of the bleeding, and, this is so important, whether or not the patient wants to have children in the future.
Broadly speaking, we can split our management options into two main pathways: medical and surgical. Medical therapies are almost always our first line, especially if the patient wants to preserve her fertility. We start thinking about surgery if those medical options fail, if there's a significant structural problem causing the trouble, or if the patient is really just looking for a definitive final fix.
This table is a great look at your first-line medical options. The levonorgestrel IUS, or LNG IUS, is by far our most effective tool. It reduces bleeding by up to 95% by causing profound thinning of the uterine lining. For a non-hormonal option, tranexamic acid is fantastic. It's an antifibrinolytic, which basically means it stops blood clots in the uterus from breaking down, and that can cut bleeding in half. And of course, NSAIDs and combined oral contraceptives are also great options that help by reducing prostaglandins and stabilizing that endometrium.
Now, on the surgical side, your options really run the gamut. They range from endometrial ablation, which destroys the uterine lining, all the way to a myomectomy, where we just remove fibroids while keeping the uterus for future fertility. Uterine artery embolization is another cool option for fibroids that works by cutting off their blood supply. And then, of course, for the definitive cure, there's hysterectomy, the removal of the uterus.
Okay, to wrap this all up, I want to leave you with one single clinical pearl. If you only remember one thing from this entire explainer, please make it this. Here is it. If you see an adolescent patient who's had heavy menstrual bleeding ever since her very first period, since menarche, and it's not getting any better with standard treatment, you absolutely must suspect an underlying coagulopathy. This clinical picture should scream von Willebrand disease to you, and you need to order a coagulation workup. This is a classic board exam question, and it's a truly critical clinical scenario to recognize.